Welcome to this explainer on abdominal vascular anatomy. Let's be real, if you've ever stared at a dense page of anatomical notes and wondered how on earth you're going to memorize that spaghetti-like mess of vessels in the abdomen, you are definitely in the right place. Today, we're taking those dense source notes and engineering them into a high-yield, totally memorable roadmap, and this is specifically designed for high-stakes exams and surgical review. We aren't just rattling off names here, we're building a true 3D spatial understanding that's going to save you at the testing center, and more importantly, in the operating room.
To build a rock-solid mental scaffold, here's our roadmap for today. We'll hit the abdominal aorta highway, the blood supply of the gut, venous return, the portal system, the surgical anatomy of the spleen, and finally, the esophageal vascular supply. Let's jump right in.
All right, Section 1, the abdominal aorta highway. We're mapping out the main artery.
Look, if you want to crush your anatomy boards, you've got to stop thinking of the aorta as a flat 2D drawing. Think of it like a 3D tube with very specific exit ramps that are organized into three distinct vascular planes. We've got the anterior midline plane, which is dedicated exclusively to the digestive tract. Then there's the lateral plane, projecting out sideways to supply the urogenital and endocrine organs. Think kidneys and gonads. And finally, the posterolateral plane, which feeds the diaphragm and the body wall. If you organize your memory by these three planes, recalling the branches under exam pressure becomes infinitely easier.
Now for spatial orientation, and examiners absolutely love testing this. You've got to pay close attention to the anterior relations. The abdominal aorta isn't just sitting there all by itself. It's buried under some critical structures. You absolutely must know that the body of the pancreas, the superior mesenteric artery, the third part of the duodenum, the left renal vein, and the splenic vein all cross directly over this massive vessel. Memorizing these crossing points is a classic board examiner's trick to test your 3D spatial awareness.
Let's anchor this to real life for a second. Check out this CT scan. You see that huge, bulging dilatation? That is an abdominal aortic aneurysm, or AA. Notice how it's characteristically infrarenal, meaning that massive bulge happens below the level of the renal arteries. When a surgeon actually goes in to repair this, they have to physically navigate through those exact anterior structures we just listed to clamp the aorta. This right here is where textbook anatomy meets life-saving surgery.
Moving on to Section 2, blood supply of the gastrointestinal tract. We're taking those anterior exits. Seriously, if you take away just one memorization aid from this entire explainer, make it this rule of odd numbers for the gut's blood supply. The three main arteries supplying the gastrointestinal tract emerge at very specific vertebral levels. The celiac trunk for the foregut emerges at T12. The superior mesenteric artery, or SMA, for the midgut comes off right below it at L1. And the inferior mesenteric artery, or IMA, for the hindgut drops all the way down to emerge at L3. T12, L1, L3. Lock that into your brain right now. It is a structural guarantee for exam success.
Zooming right in on that T12 exit, we find the celiac trunk. It's this short, stubby little vessel that almost immediately splits into three vital paths. You have the left gastric artery heading up, the common hepatic artery heading right toward the liver, and the notoriously tortuous splenic artery snaking its way over to the left. These three branches literally form the vascular foundation for your entire upper GI tract, the stomach, the liver, and the spleen.
When we put the raw cadaveric dissection right next to the stylized textbook diagram, you see something pretty amazing. It looks like a chaotic spaghetti mess in the cadaver, but actually, these three major vessels, the celiac, the SMA, and the IMA, perfectly divide the territory of the entire gut. It's a highly organized, non-overlapping distribution of blood flow from the lower esophagus straight down to the upper rectum. This is the surgeon's exact roadmap for any bowel resection.
Okay, Section 3, venous return and the IVC. Time for the systemic return trip. So, the blood's been delivered, right? Now it needs a way back. The inferior vena cava, or IVC, is that primary venous highway back to the heart. It starts all the way down at L5, formed by the union of the two common iliac veins. From there, it shoots straight up the right side of the spine, collecting tributaries from the body wall, the kidneys, and the gonads, all the way up to the hepatic veins before it pierces the diaphragm at T8. Just think about the massive amount of vertical real estate this single vein occupies.
Let's do a quick active recall check. This is a classic trick question that shows up on almost every anatomy and surgical board exam.
Think really carefully about the venous return from the testicles or ovaries. How does the drainage of the right gonadal vein fundamentally differ from the left?
And here is the answer. It's highly asymmetrical. While the right gonadal vein takes the easy route straight into the IVC, the left gonadal vein has to take the scenic route. To cross the body, it makes a sharp 90-degree detour and drains into the left renal vein first, which then carries that blood over to the IVC. Clinically, this is exactly why a left-sided varicocele is so much more common than a right-sided one. That 90-degree angle creates a whole lot of resistance.
Section 4. The portal venous system, the hepatic detour. As a surgeon, you've got to conceptually firewall the systemic IVC drainage from the nutrient-rich, filtering path of the portal venous system. They are totally different. The IVC is essentially just a pipe. It drains the body wall and urogenital organs directly back to the heart. But the portal system, that's a security checkpoint. All the blood from your gut, which is loaded with nutrients and potential toxins from your food, is forcibly routed into the liver for processing before it's ever allowed to join the systemic circulation. Trust me, mixing up these two systems is a fatal flaw.
Now visually, the portal vein doesn't just pop out of nowhere. Look at how it's formed directly by the union of two massive vessels, the splenic vein coming over from the left and the superior mesenteric vein pulling blood up from the intestines. Right behind the neck of the pancreas, these two merge to create the portal vein, shooting all that nutrient-heavy blood straight into the liver.
Moving to Section 5, Surgical Anatomy of the Spleen. We're navigating the left upper quadrant.
Okay, there is a crucial piece of surface anatomy you've got to memorize here. The spleen sits deeply protected directly opposite ribs 9, 10, and 11 on the left side, which means if a patient comes in with a fracture to those specific ribs, that is a massive red flag for a ruptured spleen. But here's the ultimate Socratic question for a surgeon operating in this tight space. When you're rushing in to remove a bleeding spleen, what adjacent structure must you absolutely identify and protect at all costs?
The answer is literally right between the vessels. You must protect the tail of the pancreas. Notice how it extends straight into the hilum of the spleen. And look at how it gets there. It's tightly sandwiched by the wildly tortuous splenic artery right above it and the straight, thick splenic vein behind it. If a surgeon just blindly clamps the splenic vessels at the hilum, they'll crush the tail of the pancreas. That leads to a catastrophic postoperative leak of digestive enzymes straight into the abdomen. Precision here is quite literally life-saving.
Last one. Section 6. Esophageal vascular supply. This is where the two systems literally collide.
Because the esophagus is so long, traveling all the way through the neck, the chest, and the abdomen, its arterial supply is strictly regional. It just grabs blood from whatever is closest. A great way to remember this is the acronym TAG for the arteries moving down. Thyroid in the cervical region, aortic branches in the thorax, and the left gastric once it pierces the diaphragm into the abdomen. It's a beautifully pragmatic design, right? But while the arteries are playing nice and straightforward, the veins are a total minefield. The lower part of the esophagus is a medically critical zone because its venous drainage creates a portosystemic anastomosis. It's basically a border crossing. Right at the lower esophagus, the systemic venous system, represented by the azygous vein draining up into the chest, physically connects with the portal venous system, represented by the left gastric vein draining down into the liver.
And this physical connection, it's practically a ticking time bomb in emergency medicine. In cases of severe liver disease, like cirrhosis, you develop portal hypertension. The liver essentially turns into a brick wall. Blood can't get through, so it backs up. It backs way up the left gastric vein and forces its way into that portosystemic anastomosis at the lower esophagus. Those tiny esophageal veins engorge, creating life-threatening esophageal varices. If they rupture, the patient can rapidly bleed out. So understanding this vascular roadmap isn't just about passing a test. It's literally about predicting pathology.
So what does this all mean for you? We've covered the aorta, the gut's arterial supply, the IVC, the portal system, and two totally critical surgical junctions. By taking these isolated branches, vertebral levels, and tributaries, and transforming them into one logical, interconnected roadmap, you aren't just memorizing lists anymore. You're visualizing a dynamic living system. You are now fully equipped to navigate both the exam room and the operating theater with the precision of a true expert. So how will this roadmap change the way you approach your next patient or your next board exam? Keep reviewing these core principles, and I promise the complex anatomy of the abdomen will become second nature. Keep learning and keep mapping it out.